Hi, this is Brian Shapiro from CTA Lab. Today's talk is on cutaneous fungal infections. This is an enormous subject, a kind of bear of a subject. So what I've done is put together a little PowerPoint on the basic fungal infections, and then given these are so rare, I have pulled some slides from Path Presenter, and I'll show those, and then I'll also show some slides from our own records. So cutaneous fungal infections are usually divided into the superficial type and the deep type. Superficial ones are Candida, which is usually yeast and pseudohyphae, and with the histology of that, it's usually epidermal change with spongiotic change or psoriasiform change. And the deep fungal infections are a whole much bigger group, and this is usually a dermal process. And the inflammatory cell infiltrate can be neutrophilic or granulomatous. There's often giant cell formation. There's overlying pseudoepitheliomatous hyperplasia. And many of these are in immunocompromised patients, and we'll go through that group. So for the superficial fungal infections, these are usually caused by dermatophytes, and these or molds, and these consume keratin. And the most common ones we see are Candida, which can be acute mucocutaneous Candida or chronic mucocutaneous. Candida can disseminate. And then lastly, Candida onychomycosis. And I'm going to leave that out because Curtis is an expert on nails, and so we'll have that talk another time. So fungal organisms are eukaryotic organisms. They have no chlorophyll. And I thought we'd just go through some of the morphology of fungi. The filaments in fungi are known as hyphae. They can be septate or non-septate. And pseudohyphae are non-septate, but they mimic hyphae because they're elongated, but they don't separate from the mother cell. So you kind of see pinched in budding, but not real septae. Mycelium is a mass of hyphae, and spores are fungal forms which can survive in unfavorable conditions and reproduce by, this is part of the asexual reproduction of fungi. And conidia are specialized forms of fungi, and they are found in the sporangia. So I think we'll just go through some of these on a chart here. So here we have hyphae with septum. So these are septate hyphae. This is growing up, so this is known as an aerial hyphae. Here's a conidiospore, which then gives conidia, which are commonly known as spores. And those are the different kind of fungal patterns that you can see. So dermataceous fungi are those which have pigment in their walls, and superficial fungal infection is commonly known as tinea. The dermatophytes that cause most commonly superficial infection are microsporum, trichophyton, and epidermophyton. So let's go through some of the deep fungal infections. And the first one I wanted to do was aspergillus. This usually occurs in immunocompromised people. It can be primary infection, pulmonary infection, or very rarely primary infection, and then secondary due to pulmonary infection or sinus infection. The most common organism is Aspergillus fumigatus, and it's most common in immunocompromised patients and can present clinically with crusted plaques, erythematous papules, bullae, and the pathology of this is septic emboli, usually with a dense dermal neutrophilic infiltrate, and this is important. The hyphae have septate, and there's a 45-degree angle. An interesting fact, the primary cutaneous lesions have a good prognosis, but are very rare. The next group I want to look at is zygomycosis, or the two organisms that cause this most commonly species are mucormycosis and rhizopus. Clinically, this is usually primary cutaneous infection, which presents with a hard papule or plaque with areas of necrosis, often in diabetics. And the pathology of this is a dermal neutrophilic infiltrate with prominent edema. This one you find hyphae, but no or very few septi, and this is ribbon-like organisms, and you find that they invade the vessels. And an interesting fact with this is that you see the Splendori hoopli phenomenon, which is the organism in the center and radiating pink fibrinous material around it. So that's a common, a finding that will clue you into that it could be zygomycosis. The next one is blastomycosis. This again can be primary or secondary. Most commonly it follows pulmonary infection and then disseminates. The primary one is very rare, and this presents with papules, pustules, again, lots of different clinical presentations. The pathology of this has verrucous epidermal hyperplasia, and I'll show you that later in the slides, with neutrophilic microabscesses. So when you see that, that's a tip-off to blastomycosis. Early on, it's got a neutrophilic infiltrate. Later on, there's a histiocytic infiltrate with giant cells. And the organisms are oval, not encapsulated, that's important, and budding yeasts with a broad base. And this is compared to Cryptococcus, which is budding yeasts with a pinched off base. And the Cryptococcus also has this capsule, gelatinous capsule. Interesting fact with blastomycosis is that it's not common in HIV patients compared to coccidio and histo, which, as you all know, are more common in HIV. The next group is paracoccidiomycosis. This usually is quite rare. We don't see many cases of this. It usually starts with inhalation into the lungs and often is very symptom-free. It usually resolves with a fibrotic scar in the lung, but in very rare cases, you can get dissemination and you get acneiform lesions in patients present with ulcer or abscess formation. Again, this has pseudoepitheliomatous hyperplasia. It has a suppurative and granulomatous infiltrate with giant cells, just like you see in blasto. And the organism in this is a spore with circular buds of organisms, which is commonly known as a mariner's wheel. Okay, the differentiation of blasto, crypto, and histo from this can be very difficult. Not so much histo because that's a smaller organism, but blasto and cryptococcus can be really difficult. The next one is lobomycosis. This usually presents with a smooth keloid-like scar reaction, often in the lumbosacral region or on the face, extremities, and thorax. Usually primary trauma, animal bites can cause this. And the pathology of this compared to the ones we just saw is an atrophic epidermis with a dermal infiltrate of macrophages, giant cells, and very foamy histiocytates, another clue to the diagnosis. They're spores which don't stain with H&E, so you just see the empty vacuole, and very few newts or necrosis. So if you see newts or necrosis, it's against lobo. And transepidermal elimination is common. The next is one we see fairly commonly, chromoblastomycosis, the copper pennies. This is usually a local infection which does not spread. It's often due to minor trauma. They have scaly, non-pruritic papules which grow and spread via lymphatics, so you get this lymphatic spread. This one has pseudoepitheliomatous hyperplasia with abscess formation. You get parakeratosis, spongiosis, and then a dermal suppurative and granulomatous infiltrate with giant cells, eosinophils, and plasma cells, and these characteristic copper penny, the brown thick-walled fungi. Useful fact is budding is not a feature in chromoblastomycosis. The next one is probably well known to you, Cryptococcus. This usually starts with airway infection and is disseminated with cutaneous involvement in 20% of cases. Very, very rarely primary, and often you see scalp and acneiform lesions on the face. And this is a characteristic pathology with these gelatinous areas, the gelatinous type, and there's also a granulomatous type where you don't see as many organisms. There's the mucoid background in the gelatinous type with very little tissue reaction. And in the granulomatous type, you obviously see granulomas and giant cells. And these are budding yeasts with a capsule, and the capsule stains with Alcium blue, and there's pinched off budding. The next is one which we don't see that often, coccidiomycosis. And this is primarily seen with Coccidioides immitis, and these are fungi which are found in soil, and it's usually acquired by inhalation of the conidia. So the lungs are the most common site of infection, and then you can get, mainly in immunocompromised people, dissemination, about 5% of patients. Usually presents as a painless nodule. The pathology is a hyperplastic epidermis, dermal granulomas, and these spherical organisms with a double refractive outer wall, and these can be pretty difficult to find, and they're big. So the histologic differential here would be rhinosporidiosis. The next one is one that's fairly easy to diagnose, phaeohyphomycosis. This usually follows traumatic injury, starts as a papule and then progresses to a suppurative lesion, often a cystic or nodular lesion on the feet, knees and toes. The pathology of these is a dermal process where you see a cystic lesion, often with a fibrous wall, granulomatous reaction, and pigmented hyphae with melanin in the wall. And sometimes it's hard to find the hyphae and pigment. You can do a Fontana-Masson stain, which stains the melanin. The next one is histoplasmosis. This often is subclinical pulmonary involvement, and in HIV patients, there's usually is where this occurs with dissemination. And this is known as the syphilis of fungi because it can present with such a clinical, large number of different clinical presentations. An ulcer, a chancre, you can have regression, papules, pustules, pyoderma gangrenosa-like lesions, oral lesions, genital lesions. So it's always something to think of in immunocompromised, especially HIV patients. The pathology of this is a perivascular neutrophilic infiltrate, can be quite subtle if the patient's immunocompromised. And if the patient is immunocompetent, then you see granulomatous and caseous necrosis. And these are small budding yeasts, which are usually smaller than the red cells and are intracytoplasmic. And again, this is known as the fungal syphilis. Next one is sporotrichosis. And this, like chromomycosis, is primary inoculation, usually with a thorn or a splinter. It can be a delay of up to 6 months to get the clinical signs. So often the history can be tricky to get. And it presents with a painless papule, which then can have lymphocutaneous spread. So the clinical forms are either the fixed cutaneous one, which is a solitary verrucous encrusted plaque, or a group of them, or the lymphocutaneous ones, where it starts on the fingers and then you have dissemination up to the lymph nodes. The pathology of this is intraepidermal abscess formation with neutrophils, epidermal hyperplasia, a dermal mixed cell infiltrate with newts and lymphocytes, granulomas, and the fungus is very hard to find, and usually if you do find it, you have these cigar-shaped medlar bodies and spores. You can find asteroid bodies in 40% of these. And then the last one in the talk I'm putting here is rhinosporidiosis. This usually is clinically characteristic. It's a mass blocking the nose or nasopharynx. You have epidermal hyperplasia and papillomatosis, and these big sporangia. So these are huge, with central sporangia, spores, granulomatous inflammation, plasma cells, and eosinophils. And the differential of this is myospherulosis, which is oil-based hemostatic packing. And I thought I'd just show a picture of this because this is myospherulosis, and this you could think was rhinosporidium, but this is due to the oil in the packing of the wound. So now let's do some more fun part of this, which is looking at the slides, and these are from Path Presenter. And the first slide is a nice punch biopsy. You can see a relatively normal epidermis, and large dilated vessels here with something going on. This vessel wall is not normal, and very little else, other inflammation, sparse perivascular infiltrate. When you look at the vessel, there's an intravascular thrombus, and here very nicely in the vessel wall, you can see these septate hyphae, and they are 45-degree angles. It's kind of tricky, but you can see there's a 45-degree angle, and they also hyphae in the thrombus. So this is aspergillus in immunocompromised patients, and these patients have a poor prognosis. Here you can see really nice septate hyphae organisms, and the walls are parallel. Here more organisms. So this is a nice case of aspergillus, and here's the clinical of that case, which was a plaque, some ulceration, so immunocompromised patients, and this is almost like an eschar. And here is another case of that. And again, you see a normal epidermis, and this has got a lot of hemorrhage. There was probably vascular damage, an infiltrate, superficial and deep. And then when you start looking, the infiltrates neutrophils mainly, neutrophilic microabscesses. And then over here you can see these septate hyphae. And this is aspergillus, which has destroyed this vessel. And this is so clear, even on H&E, you don't really need a PASD stain to find the fungi. Another vessel here. And very little granulomatous infiltrate, mainly a neutrophilic process. But the diagnosis is down here. Okay, the next one we have is a shave biopsy. Get this around. And again, there's no pseudoepitheliomatous hyperplasia. You've got scale crust here with parakeratosis, serum, some inflammatory cells. And in the dermis, you can see there are these brown blue cells, which are lymphocytes, and then these organisms which have a gelatinous capsule. And there are many of them. See over here. Yeah, beautiful. And the areas where you can see if they bud, you'll see pinched off budding. I'm not finding it here nicely, but this gelatinous capsule is really characteristic. You can see eosinophils here. And this is Cryptococcus, the gelatinous type. And yeah, this is usually Cryptococcus neoformans, but there are other ones that you can get. Here is another case of get this. Here we go. Of Cryptococcus. And here you can see relatively normal epidermis, a lot of edema, some vascular dilatation, neutrophils, and here you can see the organisms, again with the gelatinous capsule, which would stain with mucicarmine or calcium blue. Areas of necrosis in the dermis, and many, many organisms. You can see them all around here. Here's the last one of these, which is again a nice, looks like a punch, relatively normal epidermis. And this has a more granulomatous infiltrate. You can see these histiocytes, lymphocytes, giant cells over here. So this is the granulomatous variant of Cryptococcus. And here the organisms can really be much more difficult to find. Let's see what we have here. And these are ones you might need a PASD stain to actually find the organism. However, if you look carefully here in these areas of necrosis, here you can see them. See these little round organisms here are Cryptococcus, and again, if you did the stain, there's another one. If you did the stain with a capsule, to highlight the capsule, you would be able to show that these are Cryptococcus. But this is much less easy to find these organisms than in the gelatinous type. And here is a clinical of Cryptococcus with an ulcer, and this I think is supposed to show this kind of mucoid material that's coming out. Okay, so now let's look at something much more common. This is a shave biopsy, and at first blush it's almost normal epidermis, normal stratum corneum, but you can see there's some spongiosis, some subcorneal pustule formation, and that subcorneal pustule formation, pustular psoriasis, AGEP, pustular hypersensitivity, IgA pemphigus, but also always think of fungus. And here you can see the spaghetti and meatballs of the tinea vesicolor. And you can see them here and up here very nicely. So with a good stained H&E, you really can get this report out quickly, and you don't actually need to do the PASD stain. Okay, the next one's a little trickier. Again, a nice punch biopsy. Looks like maybe the back, eccrine glands, the follicle. And here you can see there's epidermal change with some parakeratosis, a little bit of spongiosis, and an intra-epidermal neutrophil-rich vesicle formation. And the vesicles filled with neutrophils, and then you've got a superficial perivascular infiltrate, lymphocytes, neutrophils, some eosinophils. And this one is not so easy because when you look at the scale, it looks fairly normal. But when you look on the other piece, up here, there you can see fungal organisms. Again, the spaghetti and meatballs, there's some more. So these can be sometimes tricky to find, and if you suspect a fungus in a spongiotic or psoriasiform dermatitis, order a PASD. In fact, in the lab, where we get clinicals of scaly lesions, we often just do the PAS at the beginning. And here you can see the fungal organisms. Okay, I thought I'd put some clinicals in of tinea infecting the hair. Here is a patient with a post-auricular nodule, and this turned out to be tinea capitis. And here is another scarring alopecia in a patient where the biopsy showed fungal folliculitis, and this was again tinea capitis. So the next one I'm going to show you is a phaeohyphomycosis. So here's a nice big punch biopsy, again, relatively normal epidermis, and you can see that all the action is in the mid to deep reticular dermis where there are these nodules of inflammatory cells. When you look at these, you see there's a mixture of neutrophils, histiocytes, giant cells, and if you look carefully, there's something brown over there. When you go to that brown area, you see septate hyphae with pigmented septate hyphae. So these are fungi, and this is phaeohyphomycosis. Here you can see in the giant cell some fungi, and this is a relatively easy diagnosis to make if you have this many organisms. If you don't, you can always do a PASD and a melanin, a Fontana-Masson stain to show that these are pigmented. This one was quite a lot of organisms here, you can see. Okay, I've got quite a few of these because these cases can easily be missed as ruptured cyst, response to a ruptured follicle, traumatic injury or something, and the fungus can be missed. So this looks like it was a dermal nodular lesion with a little bit of orthokeratosis and a bit of acanthosis. Very dense inflammatory cell infiltrate mixed with giant cells. and a granulomatous component, lymphocytes, and these neutrophils. And here, again, it's people see over there that brown, and there we have the septate hyphae with pigmented walls, and this is phaeohyphomycosis again. But you can see on a day when you haven't had your Wheaties, this could go and comes in as a clinical nodule. This could go as response to a ruptured cyst. So these cases where we just report, ruptured cyst, be careful that there's not phaeohyphomycosis. Can be really tricky. This was a case that also looks like fragments of an epidermoid inclusion cyst. And the clue here, and these are hard to see, is there's this pigment, and when a PASD stain was done on this one, again, this had septate hyphae and pigmented hyphae, and this was phaeohyphomycosis. Here's another one, which this one presents as the cyst with a fibrous wall, and you can see this is deep in the fat. So this was a kind of subcutaneous nodule with a cyst with a fibrous wall and a dense lymphohistiocytic infiltrate, giant cell formation. And this one was not so easy because this all looks granulomatous, not much to see. But then when you start looking carefully, see here are these brown organisms. There's some more there. There's a septate hyphae pigmented. So yet another subtle case of phaeohyphomycosis. When you start looking around, you start identifying there's some more organisms there. Neutrophils, a few over there. Yeah, you can see them. So something not to be missed. Okay, the next one, this is a fragmented biopsy. It looks like it was ulcerated. Under the ulcer is vessels with lymphocytic infiltrate, mainly lymphocytes, and then areas of necrosis over here. And in these necrotic areas, you see these ribbon-like, non-parallel walled hyphae without septate, without septi. You can see these ribbon-like organisms. So this is mucormycosis. Rhizopus is the one that I think this may have been, but and this is fairly characteristic. They love this on boards, these ribbon-like organisms, and not 45-degree angles and not septate, because both the clinical and the histology, the differential is aspergillus versus mucormycosis. So a very nice case. Imprint this with these ribbon-like hyphal forms, mucormycosis. The next is one we see fairly commonly. And this, even on low power, you see it's a shave with pseudoepitheliomatous hyperplasia, hyperorthokeratosis, acanthosis, thickened elongated rete ridges, an ulcer, and a dense inflammatory infiltrate underneath the ulcer. Slide's a bit thick, but let's see what we can see. The inflammatory cell infiltrate is neutrophils and lymphocytes, and you can see again these brown things. And these look different because they are like copper pennies. There's no budding and no hyphae. So the differential for a pigmented lesion like this is, a pigmented fungus like this is phaeohyphomycosis. But this one does not have the hyphal forms, and this is chromomycosis. Beautiful case. Here's just another example, and these often are not clinically suspected and come in as shaves. So this one, you can see the neutrophilic infiltrate, neutrophil-rich parakeratosis. This one doesn't have so much pseudoepitheliomatous hyperplasia, although there is quite a bit. And here you can see even a medium power giant cell formation, a lymphohistiocytic infiltrate. And when we start looking around here, the neutrophils, the histiocytes, the giant cells, and then there's chromomycosis. There are the copper pennies. some plasma cells here as well. Eosinophils, so EOs should not negate you making a diagnosis of fungal infection. And yeah, it was pretty difficult to find the organisms, but when you're scanning along here, there are clearly chromomycosis. Yeah, the clinical of chromomycosis, chromoblastomycosis, which is usually a primary infection, and here we have a vegetating ulcerated plaque, and this is the one that has sporotrichoid spread. And here's just a last one I'll show you of pseudoepitheliomatous hyperplasia, hyperorthokeratosis, a dense infiltrate with histiocytes, and this one's obviously an easy one. You can see the copper pennies, the chromomycosis all over the show. Areas of necrosis in the dermis. Okay, the next is blastomycosis. This was on the path presenter as a infection, oral infection with blastomycosis, which I've never seen. This is a more characteristic clinical picture where you see these vegetative plaques, ulceration on the lower limbs. And this we see not uncommonly. It's in the southern part of the US, and it's inhaled usually with the spread from lung infection. Here you see the pathology of this: hyperorthokeratosis, some pseudoepitheliomatous hyperplasia, dermal neutrophil-rich abscess formation. There's an abscess. And these organisms can be difficult to find. I think here's one here. Let's look around some more in the dermis. Mixed cell infiltrate with neutrophils, giant cells. Okay, so I was offline and I took a few minutes, about 10 minutes to find them, but here I showed how hard you can have to look to find the organisms. You have the neutrophils. Here is a broad-based bud of blastomycosis. There's the organisms and there's the broad-based bud. There's the organism and the broad-based bud. But these are pretty tricky to find, so you can use either PASD or methenamine silverstain. But the clue to this is when you see a case like this to order the stain, because you're seeing a neutrophilic and lymphohistiocytic infiltrate with giant cell formation. That's called suppurative and granulomatous. In a case like this, I would always do a PASD stain, AFB stain, and look carefully for organisms. I mean, once you've seen them, then the arrow goes, it's pretty easy, but these can be very tricky to find. Here's another clinical of blastomycosis, which is a erythematous crusted plaque. And here is another histology of blasto. Again, you can see there's mild pseudoepitheliomatous hyperplasia with an ulcer and a dense pandermal infiltrate. You go on higher power, the infiltrate is neutrophils mainly, some lymphocytes, and this one was probably an immunocompromised patient because these organisms are easy to find. And you can see the histology here, the differential is going to be Cryptococcus. And the way to differentiate them is the gelatinous capsule, which you find in Cryptococcus but not in blasto. And when you see the budding, it's more broad-based. This can be tricky, but the capsule is a pretty reliable way to differentiate the two. That's another case of blasto. And this is another clinical of blastomycosis, pretty non-specific. And now we onto paracoccidiomycosis. Turn this around. So this is the organism that infects the lung, and then you get fibrosis and then dissemination to the skin. And these are the ones that you see the mariner's wheel. So here you have pseudoepitheliomatous hyperplasia again with neutrophilic microabscess formation in the epidermis. You can see these neutrophilic infiltrate. And I've never seen it as beautiful as this, where you see the organisms with a large organism and these budding peripheral organisms here, spores, like a mariner's wheel. And I don't know where this slide comes from, but these are pretty rare to find. But look at the size of it. So that's why Rhinosporidium is the differential of this. I think many of these are organisms here. See there? So this is paracoccidiomycosis. Here is a methenamine silver stain. And you can see this case had numerous organisms. All these methenamine silver positive organisms. Here's another beautiful case of paracoccidiomycosis. Nice deep shave or saucerization maybe, and pseudoepitheliomatous hyperplasia, beautifully demonstrated here with these tongues of epidermis going into the superficial dermis. Neutrophils, dense lymphohistiocytic infiltrate, and here you can recognize these mariner's wheel-like organisms. This is paracoccidiomycosis. And the size here is a clue because these are big organisms, many of them. And again, these are best highlighted with the PASD or the methenamine silver stain. Here are more of the organisms, I think. Sometimes it's difficult to tell which are histiocytes and which are the organisms, but I think these are all paracoccidiomycosis. Here we are. The next is lobomycosis. So this one, you see epidermal atrophy in contrast to the pseudoepitheliomatous hyperplasia that you see in the others. And these present with keloid-like lesions. And remember here, foamy histiocytes are characteristic. And also you don't see the organisms in H&E because they don't stain. They're just negative space. I think these are the organisms, and again, you see many organisms with these. Yeah, it's clear space. Giant cells. And the foamy histiocytes you can see here. These are all organisms, and then here is a methenamine silver stain. It shows these numerous organisms. Yeah, you can see them highlighted with methenamine silver. Here's just another case of lobomycosis. Beautiful large biopsy, and this one had unusually pseudoepitheliomatous hyperplasia, which is rarely reported in lobomycosis. Granulomatous infiltrate. And I think here are organisms, there's one. And these are, again, just the negative because they don't stain with the H&E. And here's another more characteristic lobar mycosis where you see epidermal mild atrophy, loss of the rete ridge pattern, a dense granulomatous infiltrate, foamy histiocytes, and many, many of these organisms or spaces where the organisms were. These look to me like they're picking up some stain. So this is lobar mycosis. They like this on boards as well because many organisms without the pseudoepitheliomatous hyperplasia. Okay, the next thing I wanted to look at was a eumycotic mycetoma. So you know that actinomyces often causes mycetomas with the sulfur granules on the limbs in tropical countries, but they also are a eumycotic mycetoma caused by, not by aspergillus. So here you have this dense neutrophilic infiltrate with necrosis, and in the center here you find the granules, and when these stand up with a PASD stain, these are fungi. So this is not actinomycoses. So when you see clinically mycetomas, where we are here, most of them are actinomyces and bacterial, but there are fungal mycetomas, eumycetomas, and these are these fungal organisms in the center. Beautiful case. Okay, last of this group is histoplasma. And here you have, looks like on the face somewhere, epidermal change minimal, sebaceous glands, and then something going on here in the dermis, which is a dense infiltrate with neutrophils, histiocytes, and many of these small organisms. And some of these can be intracytoplasmic, and these are smaller than Cryptococcus or blastomycosis. And this is histoplasmosis, as you know, it probably was an AIDS patient because often in immunocompromised. And remember, this is the one that is so-called syphilis of fungi because of the very varying clinical manifestations. These yeasts are usually between 2 and 10 micrometers in size. Then lastly of this group, there's sporotrichosis. And the problem with sporotrichosis is it's extremely difficult to find the organisms. Here we have a biopsy with pseudoepitheliomatous hyperplasia, some scale crust with neutrophils, subepidermal neutrophil-rich abscess formation, granulomatous infiltrate. And this one, I don't think they could find the organisms on H&E. But when you see these neutrophilic epidermal microabscesses, this is, look for blasto, look for sporotrichosis, deep fungal infection, AFB also. And here was a methenamine silver stain, which found the sporotrichosis. Organisms. Remember, this is the one that has medlar bodies. They look like little cigars. And here is a clinical picture of sporotrichosis, often on the lower limbs or on the hands, and has sporotrichoid spread in the lymphocutaneous pattern. And here was another one in which we couldn't find, which I didn't find the organisms, but again, the milieu should alert you that this could be a fungal infection. The epidermal hyperplasia, the granulomatous infiltrate extending deep with giant cells. In these cases, all deserve to get special stains for all microorganisms. So now I'll go to some of our in-house cases. This was a nice punch biopsy. And even on low power, you can see there's something going on around the follicle. A little bit of scale up here. Some papillodermal edema, mild spongiosis, perivascular infiltrate with eosinophils. Look, quite a lot of eosinophils. And then when you go around to the follicle, see there's neutrophil exocytosis in the follicular epithelium, neutrophils inside the hair, lymphohistiocytic infiltrate, and when you look carefully, there is these organisms, fungal organisms in the hair. So this is endothrix. So for boards, you have to know which are the organisms, and it's the current organisms which are most common. And here you can see nicely endothrix, the fungal organisms inside the hair. Beautiful picture. I think I've got one or two others of these. So here's the next case, which was again a nice punch biopsy. You can see a little bit of epidermal hyperplasia, but not much. And there's a ruptured follicle with a naked hair shaft and a dense neutrophilic infiltrate, some macrophages, and inside the hair are these beautiful fungal organisms, hyphae. This is yet another case of endothrix. Just beautiful histology, and this is one you can call a clinician immediately before you even do the stain. In fact, the stain is not necessary. And here's another case of endothrix. And this one was not so, again, a similar ruptured follicle with a folliculitis, but this one, we did a PASD stain. And here you can see the organisms in the epidermis. So sorry, this was a fungal folliculitis. Yeah. And here's another case of ours, a little shave biopsy. Even on low power, you can see there's some spongiotic change here with the intraepidermal vesicle, spongiosis, perivascular lymphoid infiltrate, not a lot of eosinophils. Maybe a few Langerhans cells over here, not much scale. And hiding out inside the hair follicle is endothrix. So the rest of the biopsy looks pretty normal. So that's why in these biopsies that look fairly normal, PAS stain is always a good idea, and levels, because you can see out of all these pieces, it's only on the one on the top here that you can see the fungal organisms. And here is a case I had recently, punch biopsy, came in as eczema, hyperorthokeratosis, some parakeratosis, mild spongiosis, superficial perivascular lymphoid infiltrate. When you look carefully at the scale, there's some neutrophils, and some grunginess here, but this is very hard to diagnose. It just looks like there's something going on there. But so we did a PASD stain on this, and there clearly now you can see the organisms, the tinea vesicolor. So they can be really subtle to find, and it's a good idea to stain these eczematous reactions if you can't see it, because the only place we found them was maybe one here, but this was a little focus of these fungal organisms. So that's our cases, and then I just wanted to, there's a very good review in the American Journal of Dermatopathology on the morphologic findings of deep fungal infections, and this gives a really nice table of what they all look like in color, and then how to distinguish these, which give pseudoepitheliomatous hyperplasia, which are pigmented, which look keloid-like, which are immunocompromised patients, all the stuff you need to know. So I'll ask Sean to make this article available, and it really is a fantastic review of deep fungal infections, which is something people can find really challenging to keep everything straight. So thank you. I hope everyone's enjoyed this. It's a big subject, and keep well and keep safe, and thanks to everyone.